All right, look at this ECG and tell me where the so this is ECG of somebody with crushing severe chest pain, possibly having an myocardial infarction. So tell me the changes you see and which leads have those changes. Which ischemic changes do we see here and which leads have those changes?
Is there a certain lead you want me to focus on?
You're supposed to read all of them, so you read all of them in sequence, looking for those changes we just talked about.
Okay. So for like the AVF,
Okay, what is on the AVF?
there's uh the J point is higher than
So what do you
the
call that?
that's called ST elevation.
That's the elevation. So AVF has that's the elevation. You're right. So the J point here starting at an higher level, rather. Okay. Okay. Go ahead. What else?
In lead 3 as well, there's also a high J point.
Okay. Is that all?
In in lead, I think that's lead 2.
Mm-hmm.
There's an inverted T wave.
And
Huh?
what else? Which one is lead two? Is it V2 or 2? Which one?
Wait, is this right here?
I can see your cursor. Which one are you pointing to with your cursor?
Oh, wait, let me see if I can. Okay. Sorry. Okay. The one next to lead 2. The one right after.
This one.
Yeah.
So that's AV. Remember, I told you all the ones, so the Roman numeral for each other, right? So 1, 2, 3, right? Roman numeral, AVR, AVL,
Okay,
right?
sorry.
AVL,
AVL.
right? Follow each other. Then all right. So what does AVL have? You say inverted, right?
Yeah.
T wave. Okay, what else does it have though? Doesn't it have ST depression as well?
Yeah.
You see that or not? And look at lead 2. Doesn't lead 2 have ST elevation as well?
Yep.
Okay. So you have to be systematic and read everything. So what you can do is what? If you start from here, from this point, I can go this way,
Okay.
then come to the next level, read everything this way, go to
Hmm.
the next level and read that way I'm not missing anything. So as I go through, I'm looking at right. I remember the elevation of the patient has to be significant, right? Otherwise we don't really care much. And definitely significant for 2. ABL has some depression. I'm going to tell you why that's important soon. And then 2, 3. Now, out of the leads that have abnormality, right? So let's say we identified maybe 3 here. 4 type of abnormality and stuff. Tell me why. Okay, this one has abnormality here a little bit. Okay, so tell me which leads are, remember, for me to say there's an infarction, the leads that have ischemic changes, they must be what? Looking at the same surface of the heart. You remember when we look at the surface of the heart, and which leads look at the surfaces, correct? They have to be looking at the same. Why is that important? Because it tells me that what a coronary artery supplying that location is affected. Does that make sense?
Yeah.
But if I see a lead, let's say you see ischemic change in lead 1, you see ischemic change in lead 3, you see another ischemic change in lead B1. Are they the same, looking at the same surface of the eye? They are not. What are the chances that somebody will have ischemic infarction of all their coronary artery at the same time? What is the chances of that happening? Both coronary artery, all the branches undergo infarction, they get occluded at the same time. What are the chances of that happening? 0, very low, right?
Yeah.
And if that happens, will that person present to you in the
No.
hospital?
No.
They won't make it to the hospital. Okay, so on the changes, the abnormal ECG here or leads here, which ones are contiguous leads? Which ones are contiguous leads looking at the same surface of the heart?
No. I think AVR and
No, the ones that have abnormality, the one we circled. Those are the ones that have abnormality, isn't it? Which
yeah.
ones are contiguous leads looking at the same surface of the heart? Look.
I think,
Okay, let me rephrase that. 2, 3 AVF have ST elevation. What does that tell me? What's going on? What conclusion can I draw from that?
there's a transmural.
Transmural infarction of which wall of the heart?
Is it the was it the anterolateral?
AVF, F stands for what? And this is how you're going to be making your life easier. What does F stands for? F stands for foot, right? Where's the foot in relation to the heart? Which wall is the foot looking at in relation to the heart?
Inferior wall.
Inferior. So patient has, I see ST elevation on 2, 3 ABF. All 3 leads are looking at what? They are contiguous leads. They're looking at inferior wall of the heart. So if it has what? An inferior what? STEMI. Make sense? And like you said, transmural inflammation and transmural infarction of the inferior wall. So what will I see? Which coronary artery is affected here? Is responsible?
I
Most
think it's
likely
the
responsible.
right coronary artery.
Which branch of right coronary artery specifically?
Is that PDA?
PDA. And what lesion will you see in the PDA in this person?
Infarction?
What lesion will you see in the PDA? What level of occlusion?
Oh, 100%.
100% occlusion. Which other wall of the heart might be also infected in this person, given the artery that is involved?
You said which other?
Artery might, which other wall might be impacted in this person, given the artery involved?
AVR?
Which other wall, not lead, which other wall of the heart might be infected in this person?
The right ventricle?
What else? Posterior wall. Isn't posterior wall also PDA?
Yeah.
Right. Which other structure might be impacted? Still given the right coronary artery involvement, which other structure might be impacted in the heart? SA, AV node. Correct? That's supplied by the RCA. Does that make sense?
Yeah.
So tell me, how will I determine, right, on this ECG if the nodal cells are impacted or not? What can I look for on this ECG to tell me if the SA node or AV node is impacted?
I guess like the blood supply.
What will you look on this ECG now? This ECG, what do you know the blood supply is? What will I look for in this ECG to tell me if the SA or AV node is impacted? What does the SA node do? What's the function
Oh,
of the SA node?
like the P wave.
What's the function of the SA node? Function of the SA node.
It's to like send out like
SA node is your pacemaker, right? That is the word. Pace determines the pace of the heart. So what would I look for to tell me if the SA node is working well or not?
oh the pace of the heart. I mean like the heart rate.
Yeah, yes, the pace of the heart, which is the heart rate. So what is the heart rate in this patient?
Uh, oh, we have to check the distance between the R waves.
So tell me, what's the distance between them? How will I use that to estimate my heart rate?
How many boxes divided by 300?
So how many boxes do we have? Which boxes, small or big boxes?
Big boxes.
Okay, how many big boxes do we have between the RR interval?
Like 4?
So this is an R wave, this is another R wave. Let me use those two. I have 1, 2, 3, 4, 5, 6, 7, approximately, let's say 8, approximately, but it's about 7 point something, 7.5. So 300 divided by, let's say 7 is equal to what?
That's like 6.
Is equal to
Like
divided by 7 is what? You can use a calculator. I don't have a calculator here. Let's go, doc. Sharp, 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 sharp.
42.
Hmm?
42.
42. What is that? Is that normal?
No.
So what is the patient has? How would you describe the heart rate? The heart rate is what?
Bradycardic.
Okay. Is that an evidence to tell me that there might be SA or even nodal involvement?
Yes.
Does that correspond to our prediction of the infarction in this person? Yes or no?
Yes.
Does this make sense?
Yes.
How many questions did I ask you with this one ECG? About 8 or more. First of all, what do we see? I got to be able to find my ischemic changes. That's 1. 2, which lead? 3, which wall of the heart does that lead correspond to? 4, what is going on in the myocardium? What kind of infarction? Transmural. 5, what's going on in which coronary artery? Not just the RC, but I have to know specifically, maybe it's the PD or something like that. Then what will I see in the coronary, what kind of occlusion? What kind of lesion? Arteriomatous plaque ruptured, look like thrombus with 100% occlusion. Which other structures might be, or wall of the heart might be affected? Are right ventricle, posterior wall, SA node, AV node. What will be the consequence of SA node impaction or AV node diamesis? Bradycardia, heart blocks. Does this make sense? This is just from ECG, right? Yeah. All right. So that is important. All right. Let's try another one. Let's try another one. All right, try this one. Same thing. You look for the ischemic changes, and you tell me which leads are involved.
So that was V. So on this side is V1, V2, V3, V4, V5, V6, right?
On the right side, yeah.
And then the left side is because I
Roman
kind of
numeral 1 to 3, and then AVR, AVL, AVL. Left.
that one is kind of blurry, so I can't see it. Okay. So I see for like in V1 the the S wave is like kind of like long, like it's long, it's like it's going down.
For B1.
Yeah.
Okay, yeah, but is that an ischemic change?
No, not asking.
Okay, so we're looking for ischemic changes.
Oh,
All right.
only okay. Um, for
Because remember, the reason why am I looking for ischemic change? Because if I give you a vignette attached to this ECG, of course, I'm reading the vignette first, right? So the vignette to give me an idea of what I'm looking for on ECG. Patient has crushing chest pain, they're sweating, they have all these risk factors of arteriosclerosis, patient's like 70 years old, etc. Right.
mhm,
I'm going to my ECG, I'm thinking ischemic changes. Make sense? Because of the presentation of the person. Awesome.
mhm,
Make
yeah.
sense? Yeah. All right.
Mhm.
So go ahead.
Okay, so for V2 we have ST segment elevation.
Okay.
V3 as well, we have ST segment elevation. Um, V4 there's ST elevation as well. V5 there's ST elevation as well. And V6 too as well.
So what's the conclusion?
This is transmural inflammation.
Why? Transmural infarction. Infarction.
Yeah,
Right.
transmural infection
Okay. Why?
because it's ST elevation,
S
not
elevation. Okay. Good. Tell me location of the infarction.
um. So V2. That could be the inferior wall.
Which leads are affected here?
V2, V3, V4,
Okay.
V5.
From our previous ECG, which leads do I share with the inferior wall?
Oh, sorry, like AVF lead 1, 2, and 3.
The two Roman numeral 2, 3, and ABF, correct?
Yeah,
So where's your V2, V3, V4, V5, V6? Where are they located based on when we look at the position of the ECG leads? Where do we normally place them?
they on the chest, like
The
if
chest. Where on the chest?
the in the middle. to
Okay,
the
so V2, V3, V4 anterior. Where is V5 and V6?
the axilla. That's on the like the left.
Okay, right. Okay, so what wall of the heart did these ECGs correspond, these leads correspond to?
The anterior anterior.
Anterior,
Is it called anterior lateral?
anterolateral
Anterior lateral.
wall. Anterior wall being the V2, V3, V4, lateral V5, V6.
Mhm.
Does that make sense or not?
Yes.
Yeah, anterolateral. Transmural infarction, the anterolateral wall, which corresponds to like the left ventricle, basically. So what or which coronary artery is likely occluded
The
in
left.
this person? Left coronary artery, which branches of the left coronary artery? The
Uh,
LAD, right?
yeah,
Or
LA.
LAD and left circumflex. So left circumflex supplies the lateral wall, left anterior descending supplies the anterior right wall. Good. So right
Left circumflex artery and left anterior.
descending LAD. Yeah. So development of the left coronary artery. Okay. So this LCA fraction. What lesion will I see in the LCA?
100% occlusion.
What is causing the 100% occlusion?
Um, atherosclerotic plaque.
Ruptured, right?
Yeah.
Plaque with what? So once the plaque ruptures, what will form there? Platelet clot
Yeah.
will form. Good. And that will be 100% occlusion of the artery. Very good. So very good. And yeah, so those are going to be the takeaway, right, for this one. Is that clear? Make sense?
Mhm.